that is one category of how electrical injury can occur. So it may not go through your tissue, but if it arcs, then even if it doesn't go deeply into the tissue, that arcing can cause an arc flash, which can be hot enough to cause thermal insult. And if it's a big enough arc, this is a whole different conversation. If it's a big enough arc, that arcing process and creation of plasma can create a concussive blast. And you can actually have scenarios of a lot like blast injury.
You on 8? You on 8? Okay, you're clear. Stand by for your base.
Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. I am your host, Will Berry. I am a critical care flight paramedic in North Carolina, and I'm joined by my co-host, Ross Orpit, who is an emergency physician and an EMS physician in Southwest Colorado. What's up, Ross?
Hey, Will. I'm super looking forward to this show. But before we get to it, I do want to just give a couple of shout outs. So we are actually this June 10th, probably when we release this episode, just 10 days from now, we're going to be at the Fast 24 EMS conference in Wilmington, North Carolina. So if any listeners out there are going to be at that conference, find our booth, seek us out, come say hi to us. We would love to say hi to all of you guys if you're at that conference. And then in addition, you and I are not going to be able to make it back to the Rocky Mountain Trauma Conference, but we have been invited back, and I have convinced Avery McKenzie, who came on and did an episode with us. She's going to hopefully represent the podcast at that conference. So if you see Avery, say hi to her, and hopefully she'll get us some good interviews from that trauma conference again.
Well, very nice. Well, tonight, we're recording at night. You may be listening at any time of the day, but tonight I'm excited to have back on the show Derek Miller. Derek is a nurse by trade. He is in charge of outreach for the University of North Carolina JC Burn Center in Chapel Hill, North Carolina. He has a Master's of Science in Nursing and spent over a decade at the bedside as a nurse. Tonight, we are going to be talking about electrical injuries and lightning strikes, which is a great topic as we move into the summer. If you have more questions about burns specifically, we did a 2-part series where we deep dove into burns and fluid resuscitation with Derek. But Derek, thanks so much for coming back.
Thanks for having me back. I had a blast with those first episodes, and lovely to see you again. You too, Ross.
So jumping right in, we're moving into summer.
Mm-hmm.
How many lightning strikes will you guys take care of in the burn center?
So it's going to be a relatively rare when you, in the grand scheme of things, of total number of burn patients that we see. So maybe a handful, if that. When we look nationally, kind of zoom out, if you will, then again, depends on who you ask, but we might have maybe between 400 to 800, maybe 1,000 injuries of that kind, but the mortality rate's relatively high based on mechanism of injury.
You drew a distinction earlier before we started recording, electrical injuries and lightning strikes. There's a whole breadth of specific injury patterns we may see as it relates to electricity. What are some of the different distinctions within that subcategory of patients?
Sure. So it's almost a double entendre because I reference electrical injuries as an umbrella term in two senses. So the first, etiology or mechanism of injury, in the sense that lightning strike is one very like a visceral, evocative image, but it's one mechanism of injury, relatively uncommon. But then there's, am I coming into contact with either high voltage power lines, doing construction, I'm a line worker or whatever, I'm digging underground, whatever, or low voltage injuries, which is really 90% of electrical injuries broadly are low voltage injuries that occur in a residential setting. Okay. And then there would be direct current, coming in contact with a battery, something of that sort. So those are broad distinctions: high voltage, low voltage, direct current applications. And strictly speaking, lightning would be a subset of direct current, although, it's in a special class all its own.
Well, I'm interested to dig into more. I wanted to tee things up a little bit with a case as it relates to electrical injuries. So I responded to an industrial area. It was a warehouse facility teeming with multiple buildings, lots of semi-trucks moving to and fro.
Uh-huh.
You can maybe kind of picture that.
Sure.
This one particular warehouse, there was a guy up in an articulating lift who was trying to gain access to the roof of one of these buildings. Well, while he was trying to sort out the best way to get on the roof, he put his lift up right into some power lines. It completely fried the controls, so the lift was stuck in the up position, and he was complaining. He would yell down, "I'm burned, but I can't move."
Wow.
So he was complaining of some paralysis. We ended up getting him down. That was a complicated endeavor that
So this turns into high-angle rescue.
yeah,
right?
those folks did a great job with that. His coveralls that he was wearing, which had a lot of synthetic material, were melted, and he definitely had what looked like some full thickness burns, which again, we went into depth with gauging depth of burn in our previous episode. His full thickness burns in terms of total body surface area didn't look like a whole lot, but he was in a bad way. You could tell this man was in a lot of pain. He was acting sicker than he appeared. Is this a common presentation? What's happened to this gentleman?
So a few thoughts here. Absolutely, it's not uncommon for an electrical injury, particularly when it's high voltage in the scenario that you're describing, for the full extent of injury to be far beyond what you can visibly see. And even though you saw full thickness injuries, it's probably not reflecting full extent of injury in a variety of levels, both raw tissue and then any changes to conduction system, whether that's CNS, PNS, or cardiac conduction. So lots of opportunities for damage beyond what we can see from the outside. Very common.
As we approach this patient, maybe we're able to get him down from his lift. What are our immediate thoughts? Anything unique to this patient subset? What are the things you like to tell people to look out for?
Well, it depends on who you are and when you are, but for EMS, for the first responders, I mean, cannot be emphasized enough, the scene safety aspect. So what you're describing, it's not uncommon. There's plenty of case reports for either a coworker or a well-meaning first responder coming into the danger zone and being daisy-chained and also being injured. So number one, scene safety, making sure whatever the source of electricity is de-energized by whoever needs to do that. So that's thing one. And then thing two, like from a scene safety perspective, like there's a whole subset discipline of the aerial device, the articulating bucket truck, the cherry pickers, however you want to call those things, that newer, more modern machines need to have manual releases in that exact scenario, so that if it's fried, how do we safely lower it so we don't put other people in harm's way? So those are two things that come to mind right out of the gate. Scene safety for all people so we don't have multiple injuries or multiple victims, if you will.
Derek, what do you mean by daisy chaining?
So one of the things to look out for is current passing through the human body is likely to cause depolarization of cells. And when that comes to the innervation of muscle cells, it can cause flexors in particular to contract. So if my hand is in contact with whatever the current is, and then my hand muscles flex, and then I grip it, now I can't let go of the thing that's hurting me, okay? And actually what's referred to in the electrical industry as the let-go current, the amount of amperes that causes one to be unable to let go, is actually, no pun intended, shockingly small. And so if those flexion muscles are activated, now I can't let go. So I'm literally there stuck being subjected to devastating current and can't let go. Person B, whoever that is, comes up. They don't know this is happening, so they grab me to try to take me off, and now the current's passing through me into them. So that's what I mean by daisy chaining.
Does the type of current make a difference with that?
Broadly, and I can't point to research that delineates statistics for both. By far, alternating current would be far more common. And then secondly, for the extent of tissue injury to exceed that let-go current, we're typically talking higher voltages, far less common on your 110 wall outlet, etc. in a residential setting. Far more likely either, your heavier duty one for your dryer or at the circuit breaker panel or in an industrial setting, as Will was describing.
When we first approach this patient, or the scene is safe and now we're starting to render care to them, what about any immediate life threats that are unique to this injury pattern?
A throwback to the prior episodes for me, you look for the immediate threats to life. And particularly with electrical injuries, it's not the thermal insult that bothers you the most. And a cute turn of phrase is for this subset for high voltage, you may be more concerned with ACLS versus ABLS. So the advanced cardiac life support versus advanced burn life support, meaning big current, is it calling a lethal arrhythmia? For those who do die from like immediately after contact with high voltages, the most common presenting arrhythmia is VFib. So non-perfusing lethal arrhythmia. Or is this diaphragmatic paralysis leading to respiratory arrest? Even if the heart's beating, if I'm not breathing, it's only a matter of time before, heart's not beating either. So those are some immediate things that jump out right out of the gate. So first on scene, whoever that is, you need to be checking for a pulse. Are they breathing? Do I shift gears to immediate initiation of CPR, early defibrillation if it's a shockable rhythm, etc.?
Are some of those things self-limiting? The paralysis to the diaphragm?
Yeah, and I think what Will is getting at that I want to specifically point out is we often hear this term reverse triage. And we often hear that with like lightning strikes and MCIs, but I think, we'll get to lightning strikes in a second, but specifically if you have like an electrical injury and you have multiple patients, what does this reverse triage mean and what's the concept behind that?
Are you familiar with that?
I've not heard that phrase. I apologize for my ignorance there. Please enlighten me.
So it's an EMS thing, and the idea is like, let's say you have multiple patients that are a victim of an electrical injury. They maybe daisy chain themselves together as you described. Someone may initially be presenting in respiratory arrest, but where you may triage them as deceased in another context. In this context, you may not because of the pathology of what's happening to them. So that's an EMS that is commonly taught as it comes to electrical injuries and lightning strikes.
Yeah, for lightning strikes, absolutely. A distinction of lightning strike, even though it can be devastating, is it's one and done and you're done versus prolonged contact nominally with other types of, devastating amounts of current and voltage. So I think that's a reasonable approach that hopefully if there's respiratory paralysis, it can be transient. Now, the data is mixed in animal models and otherwise about to what extent like the cellular derangements at the membrane level is truly reversible. Getting ahead of ourselves, one of the mechanisms of injury, there's questions about how reversible some of this is, which we'll get to.
Tell me more about as the electrical current is passing through the body, this derangement you're talking about and the depolarization of the cells.
This is important to emphasize, and this was way back at the beginning when I said electrical injuries as an umbrella term is a double entendre, if you will. So one, it's different types of electricity, sure, which we talked about. But the other thing to think about is merely having electricity and lots of it, there's different physics channels involved in terms of how that's going to hurt me. So door number one, if the current is passing through me, and this is what sets it apart from traditional thermal insults, it has nothing to do with the heat, okay? So the concept is called electroporation. And actually outside of like getting badly injured, this is used to great effect in clinical science. So I can use electricity to make the cell membranes of cells in vitro more permeable. So I can put whatever DNA I want in there to do, cutting edge science. The analogy that I'll make for big current passing through, it's like every prison break movie that you've ever seen when the inmates get to the guard tower and they turn the switch and every door on cell block D opens at the same time. It's an extended metaphor, right?
Yes.
But this is the idea, right? So you are making the cell membranes more permeable, writ large. Well, the problem with that is it's submarine warfare now, right? Your concentration gradients that your cells have worked so hard to preserve with your gated channels, your sodium potassium ion pump, that ATP is driving, the concentration gradients are kaput. And one of two things will happen. If it's profound enough, you'll have cell lysis out of the gate. Okay, so the cell's non-viable from the get-go. Door number two, the cell is going to have to work its tush off, re-establishing those concentration gradients. After the poration, after the gates close, it's got to work really hard to establish the gradients. And it's going to use up all of its ATP in doing so, and it's going to be very susceptible to delayed death. But again, that has nothing to do with the thermal insult per se. It's a completely different avenue or mechanism of injury that still has a lot of question marks about it. And it can show up in weird ways, either tissue injury or CNS changes, PNS changes, or again, those cardiac conduction changes we referenced.
Yeah, when we talk about the gradient of the ions, I think a lot of us instantly think cardiac myocytes. What other parts of the body are we going to have a really negative effect on?
Is that you're making a nice electricity joke there, Nick? Nice. I'm positive you did just, I'm sorry. It's too easy. We can do this all day. Zooming out, what structures in the body are specially designed to communicate with what we would call an action potential or conveying electrical signals? So then anything that's innervated, nervous system, right? So again, going back to the CNS or PNS, obviously what will get your attention is not necessarily changes to consciousness, but it's the fact that their ventricle is no longer working, right? So the cardiac conduction stuff tends to get our attention first. Something I want to presage, I hope we get a chance to come back to, when I mentioned the electroporation business is not, I won't say it's not well studied. We've studied it enough to know that it's not well understood. There's lots of mystery to that. There can be delayed onset of CNS and PNS changes for days, weeks, months after. And so sometimes someone who was not obviously lethally injured from the get-go, they can still have debilitating neurologic changes for days, weeks, months, years after. That part's fairly well documented in the literature.
Interesting. So that deep dive goes even deeper when it comes to the electroporation. But I want to talk about the thermal injury. What I've historically been taught is an electrical injury may present. There's a couple key paramedic school test questions you always get taught. There may be an entrance and an exit. And then also the visible thermal burn may be a lot smaller relative to the actual injury. Can you help me understand these things? Is the truth behind them or where there may be some myth there?
I think it's some of both, and it's some of it's just cleaning up pedantic things about language. But from a perspective, if this is alternating current, since the direction of current is changing, and again, if we're on 60 hertz, then we're actually going 120 reversals, then there's no true entrance and exit because both are entrances and exits. So we revert to a more generic term called contact sites. So that's thing one. Thing two is it's not that clean and neat. Not all patients have two contact sites. It came in here and left here, or even if it's two contacts. Some folks have one. Some folks have 3, 4, 5, 6. So it's highly variable, but as a generic rule, I think a fail-safe is if you see one contact site, look hard everywhere else for others, because that gives you some indication for what 2 points or more did the current travel between. So if I see a contact site on both feet, well, then I know something traveled through my pelvis. If I see it on both hands, must went across my thoracic space. Look hard for that. So that's thing one. So even the thermal part, I want to subdivide, and just to let you know that what tends to be the case is if I have lots of electricity that wants to get to you, then the outermost layer of your skin, the epidermis, if it's, as long as it's dry, has relatively high resistance to flow. And so the electricity wants to get into your body, and so it may try to go, and that jumping or trying to close the circuit is referred to as arcing. And when electricity goes through a gas, air, it'll superheat the air, and we're talking generating plasma, 4,000 degrees, right toasty. So that ambient temperature in the air is what's causing a flash type injury. So that's more of a classical flash type burn, the thermal part. But once it gets into your skin, if the current gets into your body, then it will travel differentially through the body based on the resistance of the tissue. And that what we know is the deeper structures that you can't see from the outside, right? So the non-cutaneous stuff, but the deeper structures are going to hold heat in some places that hold it very, very well, or not so great for the patient, tend to be forearms up to the wrists, calves down to the ankles, where you're narrowing the extremity. And so that'll hold lots and lots of heat and not be able to dissipate it. So you're likely to have catastrophic injury in those, an isthmus, if you will, thinking geographically.
I want to go back. You mentioned flash injury. So we're talking at this point, if I understand your description appropriately, the electrical current may not have gone through my tissue. It just superheated the air next to my tissue and gave me a thermal burn. Is that accurate?
That is one category of how electrical injury can occur. So it may not go through your tissue, but if it arcs, then even if it doesn't go deeply into the tissue, that arcing can cause an arc flash, which can be hot enough to cause thermal insult. And if it's a big enough arc, this is a whole different conversation. If it's a big enough arc, that arcing process and creation of plasma can create a concussive blast. And you can actually have scenarios of a lot like blast injury.
We've spoken somewhat broadly, but also honed in specifically on electrical injury. Tell me, how does lightning fit into this? How is it different? How is it all the same?
Sure. So again, as a key point for lightning strikes, you look for the immediate threats to life, which again would be the ACLS type stuff. Did I have changes to cardiac conduction or diaphragmatic paralysis? And there's tremendous variability. There are folks who have no cutaneous injuries. There are folks who have devastating cutaneous injuries, and it's very hard to predict which is which. If there are tissue injuries, again, it may not be visible from the outside. So that's a through line for all types, that where I have the tissue injury may not be obvious from the outside. So if the patient is complaining of, assuming they're awake and alert and, whatever, pay attention to those symptoms that they're having, because that could be neurologic sequelae, or it could be because they have compartment syndrome that you cannot see yet, and a deep muscle belly or deep compartment.
Yeah, I think it's important to talk about, too, the different ways that lightning strikes can injure folks. You can be struck directly by a bolt of lightning, in which case that's a really bad day.
Sure.
But there are some other ways that you can be injured by lightning. Could you speak to those?
Lots of variety there. So the direct strike is the lightning bolt from Zeus. When it hits you. It could be what's called side strike. It hits something adjacent to you, but there's hundreds of thousands of volts we're talking here. And there's enough electrical discharge so that some of that's still moving through the ground or through the air. even if it's not a physical concrete bolt, but you get the idea. The main thrust of the lightning bolt doesn't hit you. There can still be enough dissipation of the current that gets you that way. Or it strikes something that you're touching, right? You happen to have that 7-iron in your hand, and that's what is hit. Your bag of golf clubs, to use a stereotype. The afternoon golf game, it gets interrupted by the lightning strike that wipes out half the 4 under par is no longer. But
I actually don't know how common it is of an injury pattern, but you do hear about a lot of golfers being at high risk of lightning strike. They're outside, they're in an open space. I don't think holding the 9-iron may hurt them more, but it's funny to think about somebody holding a metal stick in the air while they're in a lightning storm.
As we talk about these electrical injuries, can we get down to some numbers? Like, what constitutes a high voltage injury that we should be super concerned about versus like a low voltage injury?
An arbitrary distinction in the literature is low voltage being anything below 1,000 volts and high voltage being anything above 1,000 volts as a nominal cutoff. But even that, right, it's possible to have significant injury from low voltage. Now, it's far less common, but your catastrophic tissue injury stuff tends to correlate with extremely high voltages. But if I said high voltage, well, that could be, a 7,000 volt secondary power line leading into my subdivision, or that could be that hundreds of thousands of volts in a lightning strike, right? So those are worlds apart. But nominal cutoff below 1,000 or above 1,000 for low versus high.
And how does the, time with contact with the electricity change the injury?
That's the only saving grace of why lightning strikes are not uniformly fatal, because the voltage is so profound. The only saving grace is contact time. So there's a couple, without getting too heavily into the physics, because unless people can see the formulas and think deeply on this, it's a snooze fest right away. Or their GCS is immediately a 3 after hearing this. But so one formula that comes up all the time in talking about electrical injuries is Ohm's law, which relates 3 important quantities, and that's current. And the unit for current is amps or amperes, okay? Voltage, which is potential difference. Happily, the unit for voltage is volts. That's an easy no-brainer.
I like that.
I know, right? And resistance is in ohms, okay? So your Ohm's law formula is that current equals voltage divided by resistance. So that's one thing to keep in mind. Now, why does this matter? If you look at the outlet coming out of your wall at your home, right, we talk about that in terms of voltage, because that's what we tend to talk about things. That's 7,000 volt power line, hundreds of thousands of volts. But as it turns out, it's current, it's actually flow. So you can think of current as flow of electrons, whereas voltage is the potential difference. Now, again, unless your background's in physics or electronics, not all of us can wrap our heads around that very easily. But one thing to keep in mind is current. It's flow of electrons that causes the tissue injury. Voltage is usually what we know, so we use that as a surrogate, but that's only part of the equation. What else is there? Well, that was resistance, okay? Resistance to flow is what correlates to heat. So that's one thing to contemplate. Where there's more resistance to flow, okay, you're going to generate heat, and that's what's going to cause the thermal insult, whereas the current we're going to induce that electroporation process that we talked about before. So again, 2 pathways of injury. Now, circuitously, back to Ross's question, time of contact. All right, when you talk about the thermal insult, let's step back and tell ourselves, well, we know broadly that hotter for longer is a worse thermal burn, right? That kind of makes sense at an intuitive level. So the analog to that in electrical injuries, we would say, well, it's the power involved. So that's going to be invoking Joule's law. Again, this is deeply in the weeds now, but it's the square of the current times the resistance. When there's tons and tons of current, if you're squaring something that's already huge, we're talking enormous amounts of power. How do we get from power to injury? It's times contact. Well, lightning strikes are milliseconds. That is the only saving grace of why there's not more heat generated by those, if you will. Now, let's contrast that with the line worker who, his hand goes into flexion and he's grabbing hold of that, right? So there may be still substantive power, but now he has sustained contact time. So this is why the contact time really matters. It works in your favor in lightning strikes, not so much in those situations where, he can't get out of the bucket truck or he's pushed up against it or whatever that is.
For reference, some stats that I've seen on lightning is there may be 100 million to 2 billion volts in a single lightning strike, or 20,000 to 300,000 amps. But as you mentioned, the contact duration is incredibly short. So it's like 0.1 to 200 milliseconds. And so even though you're seeing these like super crazy high amps or voltages, that contact time is so short that sometimes it just causes that transient paralysis of the diaphragm that you talked about, a transient arrhythmia. And that if you can support their respirations, support their heart with CPR, that oftentimes that will resolve itself and those people will actually do quite well, even if you come across them and they're not breathing or they don't have a pulse.
Oh, agree entirely. They have a fighting chance. And so, again, revert to your ACLS algorithms. Again, for those who don't survive, unsurprisingly, VF is your most common presenting rhythm, but almost every arrhythmia imaginable can be your presenting arrhythmia. So, again, use those protocols to jump in with care. Totally agree, Ross.
Versus that line worker that you were talking about that may only have a couple thousand volts, but it's AC current and they get that flexion of their hand and they get stuck on that line and get that prolonged exposure to that current, which might be much more devastating.
Well, yeah, absolutely. And again, going along with that, the sustained nature of it, we're going to have a much higher potential for greater thermal insult as well. And something else in there that we've not really addressed fully is this notional sense of when we're depolarizing cells simultaneously, this notional sense of tetany. So if I'm causing massive simultaneous depolarization of cardiac conduction, well, hello, arrhythmia. If I do that for muscle cells, you can end up with compression fractures. You can end up with, long bone fractures. You can end up with the muscle pulling away from the attachment at the bone, stuff that may not be obvious, but it's not uncommon for those. Again, high voltage tends to be where we're talking about there.
And these are injuries you guys see in the burn ICU with these patients?
Absolutely. For the first responder, we've said it in previous episode that just be attentive to the polytrauma aspect, and there's no place where it's more common than in electrical injuries. Our index of suspicion is incredibly high for polytraumas of musculoskeletal variety, but also, again, we've talked a lot already about the changes to rhythms or diaphragmatic paralysis or whatnot.
So our case where we described the line worker being electrocuted, you pointed out being attentive to the immediate life threats and the polytrauma and knowing that ACLS may be the first thing we need to do to this patient. Let's say we have addressed those life threats. We're now transporting them to the hospital. Do our other considerations all still apply? We want to estimate the total body surface area. We want to gauge the depth, and we want to do an amount of fluid for these patients?
I'd say broadly, yes. There's some caveats there in that, like a quick review of what we said the prior resuscitation episode is if my gestalt says the TBSA is 20% or greater of second and third degree burns, I'm going to be like, wow, you're badly burned. I'm going to get some access, start some fluids. And we referred to the 3-tiered formula of if I start fluids, it'll be for adults, 500 milliliters an hour. For kids 6 to 12, we'd say 250 an hour. For kids younger than 6, so 5 and under, 125 an hour. The existential challenge when I'm talking about electrical injuries, well, if I'm already positing that the cutaneous injury, the TBSA that I see, might not reflect the full extent of tissue injury, well, what do I do about a 10% TBSA? I see 10%, but maybe I'm suspecting they have more tissue injury, so may need more fluid, but I don't know what it is. So there's a lot of flying blind. The broad principle still applies. They'll probably need fluid resuscitation, but even if they didn't meet criteria before, maybe I'd be kind of nudge them over the line now, so to speak, even if it's not an absolute, yes, I checked that box.
So maybe have a low threshold to get them to a burn center.
Oh, absolutely. So again, prior episode, we talked about ABA's 10 referral criteria and electrical injuries right out of the gate. We want you to be referred to a burn center. Number one, if it's a catastrophic injury, of course, because you're going to have robust reconstructive rehabilitative needs, OTPT, multiple surgeries, reconstructions, plastics, this and that. Something more insidious, and this is probably not top of mind for the EMS provider, but for a special place in my heart for the low voltage injuries, which do not appear catastrophic, and I'm not in lethal arrhythmia. I feel fine right now. I definitely felt the shock, but I feel fine right now. I don't have any, smoking cratered contact sites, no blowouts. So I'm like, nah, I don't want to hop in the ambulance with you. I'm fine. If that was a workplace injury and 6 months from now, I'm having chronic CNS, PNS changes, I've missed the opportunity to connect the dots because I didn't have that checked out thoroughly. And again, that seems like a minor quibble, but it's extremely well documented that for electrical injuries, there's a high proportion of those patients who have CNS changes. And again, some of that is cognition. I have memory loss, problems paying attention, but it's also affective disorders as well. So mood lability, new onset schizophrenia, whatever it is, those are real phenomena, but it's not as glaring as I'm bleeding out, my left arm is blown off, or whatever. It's, we still want you to get checked out so we can follow you as a patient for those delayed sequelae, because that's real in the literature too.
What would be a common low voltage source that injures folks?
Your home appliance, playing around with the inside version of the Clark Griswold special of Too Many Christmas Lights Together.
So basically anything household.
Generically true. A distinction to be made. Again, it's current that kills, not voltage, and we use voltage as a surrogate. So, if I've got the hair dryer and it falls into the tub while I'm in the tub, right, where you add water to electricity, well, number one, it decreases resistance. So there's going to be current flowing far more easily. Well, current flowing, if that's causing depolarization, now I can't move, get out. Well, it's sustained contact. So that's a recipe for, pretty quickly death in that extreme case, right? But generically speaking, low voltage, you're typically talking residential.
And I just overheard you say something I want to come back to, but a blowout injury.
Oh, sure.
Describe that.
Yeah. So it's a little bit of a fluffy gray term, but if you think of, I'll make an analogy to ballistics, so for GSW, gunshot wounds, where you may have a small entrance wound for that projectile, but because of cavitation and all this so forth, the bullet rolls and tumbles, the exit wound is ginormous compared to whatever the smaller entrance wound is. So it's an analogy, but the physics, transfer to some extent. Where the current comes in, perhaps, or a contact site, I may have just catastrophic, obvious tissue injury beyond mere skin involvement. And an umbrella term for that is blowout, where the current is trying to leave and it is wiping out everything in its path to do so. So massive catastrophic tissue injury, whether it's small, the size of my fist, or whether it's the entirety of your back. So there's a broad spectrum of that.
As I hear you speaking, it seems like you can almost differentiate these patients into two different categories: the like unconscious, unresponsive, or incredibly symptomatic patient who is exposed to high voltages, which are going to look for your life threats. You're going to look for your trauma, your bleeding, your respiratory arrest. You're going to treat via your ACLS and look for arrhythmias and treat those appropriately. And then you have your like somewhat asymptomatic patient who appears well, EKG looks normal, but is still at risk for some like long-term sequelae, like may not be at danger in the immediate period and is otherwise stable, but may have some long-term sequelae from like CNS or peripheral nervous system dysfunction that they should be transported for, evaluated, and at least counseled on to look out for.
I think that's a fair statement. And I love your phrasing of that like appearing asymptomatic, and let's say their initial EKG looks clean. So this is a key point. For low voltage exposures, as a general rule, if they didn't have loss of consciousness on scene and the initial EKG looks clean, then the odds of them developing a brand new arrhythmia 6 or 8, 24 hours later is extremely small. So I probably don't need 24 hours of continuous monitoring on that patient in an ICU. Again, if I don't see obvious injury, they appear to be symptomatic, and that initial 12 lead or that initial even a 3 or 5 or whatever looks clean, I feel better about saying, okay, you don't need to come with me right now, but we still want to see you for these expected sequelae that are going to rear their ugly head.
Out of curiosity, what are some downstream sequelae for electrical injuries?
Long-term peripheral neuropathy. So, and that could be anywhere of numbness, tingling, whatever, loss of fine motor skill. The more insidious part is, again, the affective changes, just greater emotional lability, major depression, schizoaffective disorder. And the behavioral stuff is extremely hard to tease out until you zoom out to epidemiology and look at large numbers of these patients because they've been through something traumatic, right? So is this PTSD? Is there something different? And the literature suggests this is something different than just your garden variety PTSD. You had near-death experience, something bad happens to you, whatever. There's actually changes to your neural structures. I mean, it would show up on a functional MRI, but there's not a structural change. This is wandering a little bit far afield here, but it's pretty well documented for folks, let's say, with major depression, that one tool in the toolbox is what's called transcranial magnetic stimulation. You give them a helmet that makes them look like Professor X wearing the Cerebro helmet there from the X-Men, but low amounts of magnetic stimulation can change functionally neural pathways and patterns in those affective orders of the brain, right? Well, magnetism and electricity are two sides of the same coin, right? So it's electromagnetic. They're just anyway, not to get too much in the physics, but electricity can do that, but it's muddy water. And so it's not a slam dunk. Again, like you're in VF, it's, wow, 6 months later, you're still depressed. And wow, you're just not who you were before. And you can't go back to work because your fine motor skill is nothing or whatever. Those are real things. So again, I encourage follow up. But to Ross's point, which is a legitimate one, right? Do you need to go in the helicopter now? If your EKG looks clean, I don't see signs of injury. That's a hard argument to make.
And then what about sequelae that you commonly deal with in the ICU setting?
Couple things. So if we have had the door number 1 variety where I have high voltage injury with obvious larger tissue injury, okay, well, if I have a prolonged ICU stay, well, automatically I get the whole bucket of nosocomial stuff that we try to fight hard on the inpatient side, right? So you're in here for 3 months. You got 5 surgeries ahead of you. Maybe you're on the ventilator. So here's your VAP. Here's your CLABSI. Here's your CAUTI. Here's your pressure injury. Here's your DVT. Here's your ICU delirium. All of that stuff. separate and apart from that physiologically, if I've caused tons of tissue injury and that has included muscle, well, see your prior episode, your excellent episode, I got to say, about crush injuries. What are we worried about in crush injuries? Well, rhabdo, right? So breakdown of muscle products, your myoglobin. It's a relatively, getting very technical, it's a relatively fatty boom batty molecule, as I call it, right? It's going to gum up your nephrons. So we're at great risk for AKI downstream of a large tissue injury below the skin where I'm in deeper structures again, muscle, from the injury itself. Or we're looking at delayed manifestation that looks like, well, it's compartment syndrome. Right. So if I have, this didn't come up before in the previous episode, I think it's useful distinction to separate compartment syndrome into subcategories when we're talking about burns. So classically, when you think escarotomy for a full thickness burn to my arm, I'm doing an escarotomy because the eschar, which is leather, is the full thickness cutaneous burn, is acting like a tourniquet around the entirety of my limb, arm or leg, whatever. So I'm releasing the tourniquet by cutting through eschar. That's classically, when we think of burns, what leads to compartment syndrome. But when you add the electrical component, because the current travels into deeper structures, and now I may have compartment syndrome in an individual muscle belly or in a deep compartment, my anterior tibial compartment, or between my radial and ulna bones, these deeper areas. And so there may not be a band of eschar on the outside to cut through. I may have to go through skin down to below the subacute fat and release the wrapper of the muscle layers. Of course, that's the myofascial sheath. We call those fasciotomies. Again, see your excellent prior episode about crush injuries. But it manifests differently, but it's no less of a danger. It's probably more of a danger because it's not as obvious. And just because you've released one compartment doesn't mean the others are not affected, etc. So those are some big concerns with electrical injuries. The risk of 6 hours from now, I have profound compartment syndrome.
Which 6 hours, that's relevant to EMS if you think about certain austere environments that people could find themselves in.
Yeah. It can happen medium fast, but also, like in extreme cases, can happen even sooner. And you may have not even a chance of salvaging a limb. The risk of amputations and severe high voltage electrical injuries, catastrophic injuries, amputations are in the water early on for some of those.
Putting you on the spot a little bit, what are some common mechanisms that get referred to the burn center when it comes to electrical injuries?
For the most part, it's the lines outside. So I'll give you, your pastiche of examples. So maintenance guy working for UNC facilities and wrong place, wrong time at the circuit box, whatever. So the main feed into a building, well, that's more than the 110 coming out of the wall, right? That's lots of juice. So coming in contact with stuff. We talk about the electrical line workers as our archetype in their bucket truck, but it was an eye-opening thought for me. A couple months ago, went out to Edgecombe County, Tarboro, to talk to their electric co-op, and they were doing a safety briefing. It's the Edgecombe Martin Electric Co-op. And they had invited a lot of agricultural farm workers because it's not uncommon for big farms that your farm machinery to have stuff that, folds up or retracts or whatever. And now I'm at risk for hitting power lines for that, right? So that's another area where people can be in trouble. They're not doing electrical work, but whatever equipment they're using comes into contact, whatever. Or your tree trimmer, right? His pole saw behind that branch, he doesn't see it, but there is a secondary line there leading to the house or off the main substation. So those are some pretty common ones that relate to, again, high voltage of varying degrees.
Will, tell us what happened with your patient you started this talk out with.
Yeah, pretty fascinating case, actually. So he was experiencing what was probably some transient paralysis to his extremities. if you can picture this, the bucket he was in had a metal railing around it, which he was touching, and then that metal railing came in contact with the line, and then it caused him to, I think what happened was the contact was just slight enough where like it wasn't frozen there per se, so the connection was disrupted, but the paralysis was there. So then he was curled up in the floor of this bucket, but it was stuck up in the air. So it's kind of a tricky rescue situation.
Sure.
Ultimately, when he came down, he had visible full thickness burns on both arms and on a leg. And as best we could figure out, that leg was in contact with that metal railing around the bucket, and the paralysis was still there. And it was a little bit surreal because here's this guy that he didn't fall and have a spinal cord injury, some other common mechanism for paralysis. He was just there, and then all of a sudden comes in contact with this electrical injury, and now he can't move his arms and legs. So you almost kind of felt like, are you sure, man? Like, could you try a little harder? Like, I bet if you really tried, you could move, but he could not. And then he had some other complaints, some shortness of breath and some chest pain, which who knows. We ultimately transported him directly to the burn center. Luckily, we're in a busy urban environment in Denver. The burn center was close and available. So that's where he went, and I did not get any follow-up on him. Yeah, I do remember, and I have a picture, perhaps if we de-identify parts of it, we could probably put it in the show notes, but his coveralls were distinct to me because they were almost all intact, except right where those contact points were. The fabric was melted.
And I think probably what Derek would say is, this guy was like in a small bucket truck, so maybe trauma was less likely, but you come across that electrical injury and somebody who's paralyzed, maybe it's transient paralysis from the electrical injury or permanent paralysis from the electrical injury, but you always have to consider in the acute phase that traumatic paralysis, because that's something that you want to be aware of and take precautions for, at least in the pre-hospital immediate phase.
Totally agree. I mean, it could be related to a fall, but again, going back to this massive tetany problem, right? So if the stabilizer muscles around my spine depolarize and I create a compression fracture of my own T5, well, that's a nice recipe for a neurogenic shock recipe. And then maybe that's going to be complete cord injury, but everything below that, we don't know. So it's muddy water, even if it's not, like, wow, that's sticking out of his, like that's obvious. It can be occult and still be quite serious.
We have someone from a burn center here. We're talking about lightning. We have to at least ask about the ferning pattern, the superficial burning that can happen in a lightning strike. Can you tell us about that?
It gets a lot of press time for, textbooks and whatnot, but I will confess, in my practice, I haven't seen it, although I don't practice in Florida. Who's the heavy, we get some lightning strikes, but there are other places that do a brisker trade in that regard. So the analogy that I'll use here in terms of visually what we're talking about, if you've seen like YouTube videos of folks doing woodworking art where they'll put two contact points for electricity on wood, and then you'll see a fern-like pattern being kind of fire catching on the wood in kind of a dendritic shape like a tree, whatever. That's kind of what it looks like. It's a pale white fern or tree-shaped pattern that emerges. It's light, it's pale, it's just on the surface, and it's in the absence of the obvious catastrophic full thickness eschar stuff. It's just that's the only sign that you've had this current passing through. Thank goodness for short milliseconds of contact time. So why do we bring it up? If my patient's found down, and all I know is they're found down, but I don't see cutaneous injuries, who thinks, oh, it's a lightning strike? Nobody immediately jumps to that, right? In the absence of a witness, or, they're sitting there with the smoldering ruins of a golf bag or whatever. But seeing those signs can point to, all right, well, this indicates the presence of electricity. So now let's start thinking about electrical injury workup. Now that presumes, they weren't found down and pulseless, like other neon signs, if you will. But it's useful as a diagnostic, really, when it's not already known this is what we're dealing with. It's an additional clue in the absence of other catastrophic tissue injury. That's what I would argue.
Yeah, and that's referred to as Lichtenberg sign or Lichtenberg figures.
Yeah, you got to be careful because my tongue always wants to say Liechtenstein, which
That's what I was going to
is a
say.
postage stamp-sized country there. But yeah, Lichtenberg.
Yeah.
So
Well, Derek, I'd love to kind of recap some of the things we've talked about. So when we're thinking about electrical injury and lightning strike patients, the first thing that you hit on that Ross and I wholeheartedly echo is scene safety. I did a quick search in preparation for this. It's not uncommon to see even first responder line of duty deaths as secondary patients responding to these incidents. One of them actually here in North Carolina that I believe was a winch cable coming off of a fire truck came in contact with the downed electrical source. So please, scene safety, it really can't be understated. It is so important on these calls. Lightning you can see, but the high voltage wire that's down but still energized, sometimes you cannot tell.
speaking at multiple electric co-op safety summits to have an appreciation of how much I don't know, because I don't work with electricity every day. But even if lines are down and the ground has become energized, even just jumping off the truck, right? They teach the linemen when they exit the vehicle, if they think their truck came into contact with something, to jump off with both feet. Because if I step down with 1 foot, then that 1 foot is completing a circuit back between the ground and the vehicle, right? In recent history, I have a patient in my mind who that's how he had a horrific, catastrophic electrical injury just from unintentionally completing the circuit. There's also called step differential, etc., which even the potential difference in charge, again, that's what voltage is. If I have 1 foot that's closer to the source of electricity on the ground than the other, well, then I'm creating a potential difference between my 2 feet. And that's enough to cause current to flow between my body because there's a delta between my feet. And sorry to shoplift your summary there, but just like the scene safety stuff, yeah, don't touch those wires, but just even being in the vicinity sometimes is enough to get people injured horrifically.
Yeah, that's great advice. Once we're able to make patient contact, remember those things we've talked about in our previous burn episode, but the thermal injury isn't probably going to kill people right away. And the same goes for these electrical burns. We need to remember there's potential for polytrauma. And as it goes with electrical injuries, maybe the line worker in the bucket truck fell out of the bucket truck after this. We need to be aware of that. The thing you touched on was the profound tetany that can happen. So our muscles actually contract so hard that they rip apart structures within our body. So having a high index of suspicion for that. And then the potential for arrhythmia and actually diaphragmatic paralysis is significant with these patients. So you may be doing ACLS or your ABCs long before you're actually concerned with any thermal injury. So please keep that in mind. Once we're treating these patients, it's relatively run-of-the-mill burn care. We're going to gauge our depth. We're going to look for contact points with our electrical injury patients, anywhere their body came in contact with that electrical source. And we're going to administer fluids. Once again, I love your down and dirty approach, which is an adult 500 milliliters an hour of ideally lactated ringers, a child 6 to 12, 250 an hour, and less than 6, 125 an hour. That math is easy on my brain. And then remember all of our other supportive care, treating their pain, keeping them from becoming hypothermic. All of those things matter. Derek, what are we missing? What are some last tidbits, if any, that you want to add?
I would say be attentive to changes in patient status. Now, I mentioned this in our prior episodes that patients are dynamic and don't be afraid to change what you're doing. If your patient's vital signs, their clinical exam changes over time, particularly if it's a longer ride and you have more time with them, you may be uncovering those other flavors of shock that we've talked about multiple times. And then it's a special place in my heart for those, again, the low voltage, not obviously catastrophic folks. Just do your best to try to encourage those folks to still seek treatment, even if it's not, you need to hop on a chopper now. We want you to get follow-up by a qualified burn center who knows what they're looking at so you can be treated for the long haul.
Yeah, that delayed sequelae, that's fascinating to hear you talk about. And that's significant because I think in EMS, if we really think about practical examples, those are patients that may want to refuse our care.
Absolutely.
Oh, no, I touched the broken blender. I don't need to go with you. My family freaked out or whatever. Keeping a high index of suspicion for that is really important. Ross, anything from your end?
No, thanks as always, Derek. You're a wealth of knowledge and so educated about these topics. It's always a pleasure chatting with you.
So we're approaching 4th of July.
Oh, sure.
You, sir, are due outreach for the Burn Center. How many digits are going to die this 4th of July related to fireworks?
Wow. How many digits? Wow. Is this a math digit or a poor phalange? So hopefully we can post this on EMS Cast, the web portion of it. So for North Carolina specifically related to fireworks, I will plug a coalition called North Carolinians for Fireworks Safety. So there is perennial in the background legislative efforts to expand sales of commercial grade fireworks in North Carolina. And when we look at other states who have done that, it's not surprising. The data is crystal clear. There's before and then there's after. They have more fireworks-related injuries, and the ones that they have are worse. And there's more property damage, and a sobering thought is about half of those injured in fireworks injuries are either A, kids who don't know better or didn't sign up for this, or innocent bystanders who were wrong place in the wrong time and they weren't the ones who did that. So I'll encourage you to go to, there's a website, North Carolinians for Fireworks Safety, become educated on the risk to life and literally limb. People lose fingers, lose eyesight, or risk to property damage, or risk to the lives of those who are coming to put out the fires for our first responders and our friends in the fire service. Sorry, I shoplifted your your fun, the fun double entendre, wordplay there.
I had a dark humor thought in my mind of just people blowing their hands off. That's all.
We see it, unfortunately.
Yeah, I'm sure.
Yeah, we do. Yeah, so hopefully we'll have none, but the date is pretty clear. The 6 weeks around the July 4th week, we have just a tremendous surge. That's when the vast bulk of 60% of our fireworks-related injuries occur then. And again, hands, eyes, disproportionately affects kids. It's serious business. And again, not trying to take away people's freedoms. There's plenty of ways to celebrate. We just tell folks in the fire service, the messaging is, look, if you want to enjoy fireworks, fantastic. Leave it to the professionals. Don't put your family and your friends at risk. Go to an event to where there's professionals who know what they're dealing with. Keep yourself and your friends and your family safe.
Yeah, very true. Can you give us that website one more time, Derek?
If you do a search for North Carolinians for Fireworks Safety, you'll be able to find it via those keywords.
Awesome. Thanks, Derek.
Well, awesome. Thanks again, Derek. As Ross said, you're a wealth of knowledge, and I learn something from you every time. So thank you.
Hey, pleasure. Thanks, Ross. Good to see you again, sir.
Derek, we can maybe do this as an outro if you have some good info, but is there any good like myths surrounding like lightning protection that exist?
I won't say it's a myth, just misunderstood, like staying away from high objects, right? Because whatever the high object is going to be the lightning rod. Hey, that's great. It's going to strike that and not you. But if you're in the vicinity, again, that indirect or side discharge can still affect you. So,
or if the tree is rotten, it can literally make it explode, which can injure you as well.
Shrapnel. I feel like there's a dad joke about shrapnel or something, something. But just because something else is higher in the vicinity, you're not protected. So I would say that's probably the biggest one, right? The best news is just seek shelter indoors best you can.